Welcome everyone. Bon après-midi à tout le monde. I'm going to be talking today about advances in clinical trials in PAH and hope for new therapies. And we're going to be talking a little bit about PAH and how it develops so that you'll understand why we need different kinds of therapies. I'm going to talk about briefly about the design of studies. I'm going to talk briefly or more at more length about several agents that look very promising. Some may be close to being available for you, others may be a bit further, and some will succeed and some will fail, unfortunately. We have to keep trying. Um, I apologize for my voice. I'm just getting over laryngitis, but I hope that it holds for the hour. And my slides won't advance. Oh, hold on. Okay. I want to begin by declaring my conflicts of interest. And these are relationships to pharmaceutical companies. All of us doing clinical research have relationships with the pharmaceutical companies. There are funds paid to our hospitals for the studies. We provide advice to the companies. And in the end, I don't make any money on this because it's my time away from earning money at the hospital. And so I end up at a net zero. But so why do we do it? And I think many of us are in the same situation. Without supporting companies intellectually, we would not be able to encourage them to develop medications for rare diseases. On the other hand, I think it's important to know that we do have relationships with these companies, and I try to avoid dealing with a single company because this way I really don't have a bias towards any of them. What I care about are the results of the studies, and I think this is the same for all the my colleagues and investigators across the country. Okay, so how does a medication get developed for clinical use? This is a pretty wordy slide, but I want to go through it because you need to know the terminology. Without knowing the terminology, you can't really understand what's going on. So first of all, someone comes up with a theory that a medication might help. Uh, there is a there are different approaches to this. Sometimes the science in other vascular diseases points to a possible parallel to PAH. Sometimes uh, companies do massive testing of compounds. I was in a laboratory in Switzerland where they were literally testing between 10 and 20,000 compounds, chemicals a day to understand the effects on cells. And that's sort of a brute force hit and miss technique, but it has succeeded in many cases. And really looking to see if there's any effect of a molecule then in cells that are growing in cultures, and then ultimately in animal models of pH. And that's called preclinical. So let's say the molecule seems to be effective in cell cultures and in animal models. Okay. At that point, one might begin a pilot study, which is often a single or double or maybe a two-center trial with a very small number of patients to try it out and just see what happens. There's very close watching of safety. There's less watching of efficacy, but we're looking for a small signal of effectiveness to encourage further study. There are trials called phase 1 trials, which test whether the molecule is safe in normal humans and what are its side effects. And it's very interesting because I'll give you an example. Sometimes discoveries are made that way. Originally, Viagra was being tested as something to control blood pressure. But the men coming in that were in the study started reporting other side effects. And I'll leave that to your imagination. And at that point, they realized that Viagra was much better for treating another issue than for treating blood pressure. They study how long does a medication last in the bloodstream? How is it handled in the body? Is it destroyed or does it pass out in our urine or in our stools? And also, we get a feel for what the correct dose might be. If it passes phase 1 and it still looks promising in the animal studies, at that point, we go to phase two. And there are different kinds. You may see phase 2A, phase 2B, etc. Phase two is in a selected human disorder over a range of doses, often with a placebo. The placebo is in an active arm to be able to compare to understand how does the medication affect the pulmonary hypertension. And often the primary measure of that, what we call an endpoint, is hemodynamic, meaning does it change the resistance in the circulation in the lungs? There are many secondary endpoints, and we have to look deeper for side effects, safety, and it also provides some proof for approval. And then we move into a large phase three trial. Now, large is relative, okay? Because large in pulmonary hypertension generally is a few hundred patients. It might be 1,000 patients or 1,500 patients in some of the very large trials. I want to compare that with diabetes and hypertension and heart failure, where it's not unusual to have 10,000 patients in a study. But they're large placebo-controlled trials looking at effects on how the person functions, effects on prognostic endpoints like hospitalization, survival, etc., quality of life, and other endpoints. And of course, the side effects and safety are studied. And it really provides the proof for approval by governmental agencies. So a medication cannot go for a governmental agency for approval until all this has happened. And the study suggests that it's both safe and effective. This process can take 10 years or more and can cost between 20 and $40 million. So it's a huge investment. And again, I'm frozen, sorry. Okay, now let's briefly talk about what goes wrong in PAH and why we need new therapies. This is a slide from 2000, and what it shows is it shows that this is a very, very little small blood vessel here, smaller than a hair. And you can see that in PAH, the cells inside here are piling up, and it's like a blocked drain. And they're proliferating abnormally. And some people have likened this to a kind of cancer or a localized tumor in a way, because the cells have lost the control of their growth and are proliferating wildly. And the walls get thicker and the chemicals they make change. And this progresses and gradually, unfortunately, it straggles off the lung circulation from inside. And it was thought that this development of cell buildup here occurred later, as you can see in this schema. But in fact, that's incorrect. The thing is, if you go back in history, people knew as early as 1958, some very smart pathologists, that the cells were piling up at a very early stage here. And we sort of forgot that because all of our therapies right now mainly act as what are called vasodilators. They relax or try to dilate the vessels. But if the vessel, I'll go back to this, if the vessel's plugged up with cells, it's very hard to get the really affected vessels to relax much. And so how are our current therapies helping? There are a lot of different ways to think about it. Maybe they slow the progression of disease, or maybe they're acting on the less blocked vessels and opening them up a little bit. But the more severely blocked vessels may not be carrying any blood. So if you look at this slide, this is a pulmonary artery, and you can see that so you asked me, why is the pulmonary artery blue? It should be red. But in the lungs, in fact, the pulmonary arteries are what carry the deoxygenated blood from the body back to the lungs to be oxygenated. So pulmonary arteries are blue, and they get smaller and smaller and smaller and branch into this very big capillary bed. And you can think of this as a tree with leaves. And what happens is the little branches on the tree get blocked, and then the leaves aren't functional anymore. And we have a huge reserve. We have enough leaves to cover 2 tennis courts in humans. And so this process can occur silently with a lot of little vessels getting blocked before the person really notices that they're getting short of breath. And so what's happening is their pulmonary vascular resistance is rising steadily. And for a while, the right heart, which has to pump through as the pressure's rising, the right heart copes. But eventually it decompensates and dilates, and it can't pump anymore. And as you know, that can be very dangerous for patients with PAH. And when we look at results, and these are mortality trends in the Canadian population at PAH. These are from my colleagues across Canada using a registry and a database. Um, they compared 2009 to 2015, which is one period, and they compared after 2015. And you can see that the curves actually match. And if you look at the survival probability, this is 1 year, but if you look at 5 years, PAH is still a progressive, unfortunately, progressive disease, despite all of our therapies. Now, we are doing better in terms of giving people, and remember, this is an average, okay? 50% of people are doing okay, or at least alive after 5 years. But unfortunately, it takes a toll on a lot of people. So we need new therapies. This, to me, is a very, very sobering paper. This was a patient in Chicago, my colleague Stuart Rich, and she got epoprostenol, which is our intravenous prostacyclin, and she wore it for 16 or 17 years and did very well. And I have patients like this too. And then unfortunately, she passed away from a cancer. And she granted her lungs for medical study. And when they did the autopsy and they looked at her lungs, you can see that her blood vessels here's the little channel in the middle, her blood vessels were as plugged up, and this is something called a plexiform lesion. They were as severely plugged as they were on day one. Now, clearly the epoprostenol had saved her life for 16 years and she was quite functional. But this raises the question about our current therapies. Are they actually doing anything to these very, very plugged up vessels? And increasingly, we suspect that they don't do much for these vessels. They're probably acting on less diseased vessels, but we have many, many hundreds of thousands of these little vessels that are still plugged up, and it would certainly be beneficial to try to get them open. So in 2023 and onwards, we need to affect the growth of cells. I told you the problem is that these vessels are getting plugged up by cells that have abnormal growth. That's called proliferation, and well, abnormal proliferation. And so we need to affect cell proliferation. The agents discussed today all have anti-proliferative effects, and that's why the new era is so exciting. As I said before, some may succeed, some will fail, but we're going to keep pushing till we find ones that work. I'm going to show you a series of overwhelmingly complex slides, even for doctors, okay? But they show how elegant, intricate, and complex our biochemical systems are in our cells. And I'm going to begin. These are slides that were generously loaned to me by Dr. Steve Provencher at the University of Laval, a colleague and friend, because he's investigating, he and colleagues, Dr. Sebastian Bonnet and other colleagues, are investigating two pathways that affect cell proliferation. We're going to talk about them before a little more now. There's an overlap between inflammation. We all know what inflammation is. Inflammation is the process whereby the body reacts to an injury or an infection, all sorts of different ways we can have inflammation. And there's an interaction between inflammation and proliferation. The cells, those cells I showed you that are growing very wildly, they actually resist cell death. In other words, it's like a tumor. They won't die by themselves unless we somehow affect their growth. And also the energetics in cells, how cells derive their energy is changed. The first group I want to talk about, the first agent, relate to something called BRD34, which is an epigenetic reader in PAH. We all have DNA, that's our chromosomes. DNA is like our computer program or like a book of letters. And you follow and you read the book, and all the letters suddenly become words and paragraphs and make sense. And they have to be read. And to read that, the DNA has to unwrap and wrap around a histone. And there are various molecules that help in this reading of the DNA. And BRD34 is an epigenetic reader. And it turns out that in PAH, there's increased BRD4. I can't get into why right now. It's, again, very complex. But what that does is it leads to excessive proliferation of cells. It changes the energetics. It makes it also behave much more like a cancer cell. So Dr. Provencher's group is looking at an agent called apabetalone, and they're doing there's a pilot clinical study and there's structuring of a phase 2 trial. The endpoint is just to see if we can do it in humans. And the secondary endpoints are some of the classic ones: pulmonary vascular resistance, 6-minute walk, those NT-proBNP levels, which are indices of cardiac stress that we measure all the time, right ventricular volume and mass, and quality of life. And it's being conducted in Quebec and now Edmonton. And everything takes money. And so there are local funds in the hospital. We try and pinch and squeeze our funds and donors' funds to support research. And there's a company that makes apabetalone, and they may choose to invest in what's a small market, but to see whether the agent helps. So they've done the pilot study, and all patients completed the study and procedures. 2 patients had you see, we look for side effects. They had a very mild elevation in liver enzymes, which is not uncommon in PAH. It's not uncommon with the other medications in PAH. So it's not particularly troubling, but it has to be watched. And these are the results. And you can see this is pulmonary vascular resistance. It fell in almost everyone, okay, which is a good sign. And the blood flow through the lungs increased in almost everyone. And these are a bunch of other indices, but if you look at pulmonary artery pressure, it fell in some, it didn't change in others. The NT-BNP level fell in some, went up in others. And the 6-minute walk distance didn't really change. But this is the type, and I don't mean this in a negative way, this is the type of messiness one sees in an early trial as one tries to understand, first of all, is this agent affecting everyone, most people, a few people, no one? Is there some clinical characteristic that predicts who's going to respond better than others? And these are exploratory trials. Now, the other thing to remember, I told you, is that we have a cancer theory of these cells proliferating. They behave like cancer cells locally in the circulation. And so they acquire cancer-like features. And there's a molecule called PARP1, which promotes this cancer phenotype, this cancer appearance. And these are in cultured human cells. Dr. Provencher's group has shown that if you inhibit this PARP1, so the white box is normal, the black box are cells from PAH patients. And here's the cells in the PAH patients if you give them the PARP1 inhibitor, and you can see it's restored. Sorry, my arrow's gone. You can see in all the boxes here, it's restored the normal pattern here. It's restored the normal pattern here. Here again, it's restored. It generally restores a normal pattern. So these are very promising data. And so the agent is called olaparib. And again, there's a pilot study that's being structured and hopefully will complete, and then a phase 1 study as well. So these studies, these agents are a little bit further off, but like I said, we have to try based on the science, and these look like they will be very promising from a molecular standpoint. The next group of agents I want to talk to you about are tyrosine kinase inhibitors. And here's another scary slide that shows you how complex signaling is. Now, what are tyrosine kinases? So they're enzymes, and I'll tell you what enzymes do in a minute. But first, I want to explain what a receptor is. A receptor sits in the wall of a cell, and it communicates with the outside of the cell as chemicals go by. And chemicals, it's specific for certain chemicals, and chemicals bind in. And when they bind in, they signal through the receptor. And what happens then is the receptor with the tyrosine kinases, they activate downstream cascades by administering, by adding phosphates, and energizing certain activities in the cell. So you have to imagine there's an upstream receptor and then downstream signaling. Now we have millions and millions and millions of receptors, and the receptors are used in every aspect of our body for the cells to talk to each other. So how do they talk to each other? Well, they talk to each other by um, something binding here. And I'll give you an example of receptors. Diabetes, insulin. Insulin attaches to a receptor. We have thyroid hormone receptors. We have cardiac receptors. When you release adrenaline and makes your heart race, that adrenaline is actually binding to a receptor. There are millions, literally, of different receptors. It's the only way cells can talk to each other. So tyrosine kinases are essential to this. And if you have receptors doing the wrong thing, you can give a tyrosine kinase inhibitor that will block the receptors. There are many families of different tyrosine kinases, and these are different inhibitors. And you can see that some are very, very specific to certain tyrosine kinases, and some touch almost every family of tyrosine kinases. I want to point out imatinib here because we're going to be talking about imatinib a little bit more. It's moderately selective. Why imatinib? Well, my friend Artie Gafrani, who's in Germany years ago, 2005, had a patient that was on triple therapy, sildenafil, bosentan, an endothelin antagonist, and a prostacyclin called iloprost. Patient wasn't doing well. So he walked down the hall to his cancer colleagues and said, what can I do? And they said, here, take 2 of these and call us in the morning. And what they gave him, no, I'm joking, but what they gave him was something called imatinib, which was by then a clinically useful tyrosine kinase inhibitor for certain types of cancers. And lo and behold, the patient got better. Wasn't cured, but everything went in the right way. And then there were a series of case reports suggesting that this was very promising. And then there was a large trial called the IMPRESS trial, which was published in 2013. It's 10 years now. And they did a phase 3. Well, it was an early phase 3, and they did a phase 3 and compared imatinib to placebo. And you can see that the people walked more. You can see that generally, it didn't matter if you were on 2 therapies, which 2 you were on. It didn't matter if you were on 3 therapies. It offered benefit. And it helped the pressure and the flow, etc. Everything headed in the right direction. And imatinib is not available. And you asked me why it's not available. And the reason it's not available is because people taking imatinib by mouth got a lot of side effects. And what happened was that people in the imatinib group started saying, I don't want to do the study anymore because they got the imatinib side effects, whereas the placebo group didn't say that because they weren't on the real agent. And you can see that here at the end, there were 80 patients that finished in the placebo group, but only 66 in imatinib. So when these data were brought to the Food and Drug Administration in the United States, they said, this is really interesting, but we don't know what to make of the dropouts. Please repeat the study. And a repeat study would have been $25 million. And so the company basically said no and walked away from it. Okay. And also, it was nearing the end of its patent life. And so the company had no financial interest to do this. And so I say tragically, at that time, it did not become available for us. My colleagues in Germany still use it and they really like it. But we're going to come back to imatinib because now people have developed inhaled forms of imatinib. And the principle behind that is that if you take it like a puffer, it goes into your airways and then will diffuse across into the affected blood vessels. And you can see that when you take an imatinib pill, the level in the bloodstream is very high and falls off. But if you take inhaled imatinib, the imatinib levels are very low. It's all staying in the lung. None of the imatinib is getting to the bloodstream. So this is a very elegant way to give a medication and get it to the place where you want it to get, but with trying to avoid the systemic effects. And so right now, the IMPACT trial is underway. It's a phase 2b/3 trial. It's 24 weeks long versus of a placebo versus the active agent, and it's enrolling. And I really, really look forward to exciting news from this. If the results are very, very promising, then maybe it'll be able to pass right in towards approval. If not, then we might need a second trial. There's another tyrosine kinase inhibitor called seralutinib, which is being evaluated. And you can see that it touches multiple different receptors, most of which have bad effects in PAH because the signaling is all messed up in those cells. And so it blocks them. You can see these red lines. It blocks a lot of the effects, okay? And so, again, people are hopeful. And the Tory phase 2 study finished with seralutinib, and the primary endpoint was reduction of pulmonary vascular resistance, and it fell. It's a fall. It's not super impressive, but it's a fall. It fell more impressively when the patients were a little sicker or had what's called a high risk score, and their 6-minute walk improved, et cetera. So these results are encouraging, and we're waiting to hear about a phase 3 trial. Possibly the company has to decide. Now I want to talk to you in the last few minutes about the agent that's most likely to arrive to us quickly and is a very exciting novel approach. And it's an activin binding inhibitor. I want to go back a little bit in history because idiopathic PAH, otherwise known as primary pulmonary hypertension, was described clinically in around 1950, 1951. Even at that time, they understood, this is 1954, that it could touch families tragically. And here's many different people in a family affected. And here's a family tree, and you can see there are different people that are affected. Distant relatives can be affected. And we now know that many of the cases of what we thought were idiopathic pulmonary arterial hypertension are now called heritable. And the most common problem is a mutation, a change in a letter on a word on a page, a mutation in a gene called BMPR2, which is a growth factor receptor. It's a receptor for bone morphogenic proteins. And what happens is, here's the receptor, BMPR2 doesn't function properly because there's a mistake in its paragraph that codes for it. And so when bone morphogenic proteins attach, they can't signal properly into the cell. And what that results in is less BMPR2 signaling, and counteracting that, there are molecules called transforming growth factor betas that, unfortunately, in PAH, favor cell proliferation and make the cells grow like a cancer. And so you have this very abnormal balance. There's less protection and unfortunately more bad stimulation. Well, an agent has been developed to try and deal with that, and it's called sotatercept, and it was reported in a large phase 3 trial in New England Journal of Medicine in 2022. So here's the BMPR2 mutation, or actually, you don't need a mutation. In most types of PAH, BMPR2 just doesn't function properly. This is the other side, that TGF beta I showed you before, except now we call them activins. And you can see these molecules trying to bind into this receptor, and there's too much stimulation here. Well, sotatercept is a molecule that binds the chemicals, the molecules that would bind into the receptor and takes them away. So what it does is it decreases stimulation or decreases signaling of this receptor and sort of restores the balance, which is what we want. And in this large trial, I'm not going to go through this in detail. This is called a forest plot. What it does is it compares placebo or sotatercept versus sotatercept. And then there's a line at 0, which means no effect, okay? Should be 1, actually. Anyway, but you notice all these different factors are favoring sotatercept here. Sex, the type of PAH, background therapy, single, double, triple, or is the patient on intravenous prostacyclin? What's the functional class? Every parameter that was looked at favors sotatercept. Now, just to make us crazy, they made this figure the opposite. So in this time, to the left favors sotatercept, and then so these two to the left favors sotatercept, and you can see it provides broad benefit, really broad benefit. And when they looked at deteriorations, and this is weeks, so this is a bit over a year, okay? there was a dramatic difference between sotatercept and placebo. Now, remember, the patients on placebo are on at least double or triple therapy generally in this study. So it's not like they're getting nothing. They're getting our current good therapies, and sotatercept gives them even more benefit. And it was real benefit. It affected deaths, it affected hospitalization, it affected worsening of PAH. All these parameters were different. So we need to lower pulmonary artery pressure. If I gave you a pill for blood pressure in your arm and said, oh, it doesn't do much to the pressure, you would say it doesn't work. We need in the future in pulmonary hypertension to show that we're lowering pressures. And sotatercept to date has the greatest drop in pulmonary artery pressure we've seen with any of our therapies. And many patients come down even much more. I can tell you many of mine have. And this is a study from Japan that shows if the mean pulmonary artery pressure is low, this is a 15-year curve compared to if the pulmonary artery pressure is high. This is survival. So we want to get the pressures down. The last thing I want to talk about for 2 minutes is just personalized precision medicine, because this is coming. Because although we're all brothers and sisters and cousins, different types of PAH may require different therapies. Right now, we give everyone all the same therapies, hoping they're going to work, of course. Some people respond, some people don't respond. We don't understand why. And also, it doesn't let us pick and say to patient A that treatment A is going to work for you, and patient B, treatment B is going to work for you. So right now, we've identified not just one gene mutation, but there are 23 genes routinely and many more that are under evaluation. So you see this is becoming very complex because all these problems can cause what looks like PAH. So imagine you have a population that's mixed. We don't know who's what in here, right? And what we do is they have high blood pressure in their lungs, okay? We don't know which of our drugs is going to work. So we give a mix of drugs, and sometimes it works, and sometimes it doesn't work. Now here's the future. The future is this mixed population. And we look at each patient in a very complex way, the DNA, the proteins, all sorts of stuff, okay? And then we establish linkages between all these factors. And we find a linkage A1, which is going to affect certain people and help them. A different linkage will affect other people. A third linkage will affect other people. And once we know what these linkages are, we can find very specific therapies for each type that will be effective for them. You don't give an antibiotic to someone without knowing what bacteria you're treating. Why is that? Because you want to make sure that the antibiotic is effective for that particular bacteria. We're sort of years behind that, although we're making rapid progress now. And I anticipate that within the next 5 to 10 years, we're going to be doing this much more routinely for patients with PAH. Okay, the future is very, very bright. I've touched on a lot of complex issues today. I'm open to questions, and I'm sorry I had to rush through it. I'm going to stop my share.
Thank you, Dr. Langleben. Okay,
You're welcome.
we have some questions that have come in. Okay, Beth is asking, actually, she's referring to one of your slides. Maybe you could pull it back up. It
Sure,
was
which one?
slide 16 that she's referring to.
Slide 16. Let me go back in.
Yep.
Here's slide 16.
So indicate
yes.
that PVR dropped, the 6-minute walk test increased, yet MPAP
Right.
didn't change much. Might this
Right.
kind of response be why symptoms and MPAP are not linear?
So it's a very complex thing, okay? Symptoms, until a person's very, very sick, they're not usually short of breath at rest. Most people have exercise limitation. And if you think about most of the tests we do to diagnose and then follow PAH, they're done at rest. Our echoes are at rest. Our caths are at rest. we talk to people about their symptoms, so at least we know what's going on. But many of our measurements are at rest, and they may be very different with exercise. So you can fairly ask me, why don't we assess everyone with exercise? It's because it's very complex to assess during exercise, and there are really no standards or very few standards for deciding, what the difference is between severe and mild. Now, all that being said, okay, um, there's a loose connect between the resting abnormalities, which tell us about resting severity, and exercise tolerance. And so the pressure doesn't change, but except in some patients it did change here. Okay, and it came down. If you look at that middle left bar graph, maybe I can make it large just a second. Okay, if you look at mean PAP, if you can see my arrow, some patients did fall. Okay, so this is what I'm talking about. The population is what we call heterogeneous. It's not everyone will necessarily respond to things. Now, it is a good thing to have PVR fall, because if pressure stays the same and PVR falls, it means that the flow went up. And it's always a good thing to have more flow, because our body's organs need flow. Many people arrive very sick, and part of the problem is that the right heart just can't pump any more flow through the diseased lungs. And we give them therapies. And the way I think our current therapies help us the most is by allowing the cardiac output to increase, allowing more flow through. And that, yes, it lessens the work on the heart a bit, but it really helps the body's perfusion. And also, it may help the person during exercise for the right heart to cope a little better with exercise. Has that answered the question, I hope?
Yeah, if not, Beth, feel free to
Okay.
type again in the chat. So Jane has a question. Does having PAH and scleroderma affect treatments?
Well, scleroderma certainly causes PAH, and scleroderma is a tough disease, because while we're trying to, fight and beat the PAH, the scleroderma is still there. Okay, it's a disease of unknown cause. The treatments are uh, not necessarily that effective, certainly in terms of treating the lungs. They're better agents now than they were 5 years ago. So let's say the scleroderma is there in the background, okay? And we're trying to treat the PAH that's caused by the scleroderma. Uh, the patients with scleroderma tend to have more severe PAH, and their outcomes are not as good, although they're dramatically better with the therapies we have now. What I want to show you, you couldn't see it in that forest plot that I showed you with all the little lines on it, was that the scleroderma group, at least with sotatercept, appears to respond nicely. And all our current therapies, there's always been a group of scleroderma patients studied, and in each of those therapies, the therapies have offered benefit to scleroderma also. So it's not a cure. What I always tell my patients is our therapies are buying time and buying you good time for us to be able to then get even better therapies for you.
Oh, and the million-dollar question.
Yeah.
Do we know if sotatercept is coming to us anytime soon?
Well, uh, it's going to be, I think, I would hope, approved in 2024. Okay. I don't have a crystal ball, but the data are very impressive. And of course, as with many things, the US approval will probably precede the Canadian approval, although I'd love to think that will be fast. Health Canada is very good. They're excellent. I think independently, they're careful. They always ask good questions about medications. They make sure we're getting safe, effective medications for our population. Um, and I know all the different regulatory agencies have a possibility for priority review. I don't know where any submission or what the status is of any submission in Canada right now. But I can only imagine that with those data, there are plans being made to make the medication as available as possible. I didn't finish on that slide where I showed you the approval, the drug development process, because there are two other steps. Once we have the phase 3 data, it's got to go to Ottawa. And Ottawa's got to agree that the medication's safe and effective. But then the provinces have to agree to pay for it. And they have budgetary issues. They may not necessarily completely understand the science. They may look at the cost of things. Some of these new medications are very expensive, and they may say, no way. Or they may say, try the cheap stuff first, even though we know that even taking less expensive medications uh, won't cure the patient, because we know from the sotatercept trial, for instance, that it was added to multiple medications in most cases and still had a profound benefit for most patients. So I think that they're hurdles. It's like a race with hurdles where you got to jump the hurdles, and we will jump the hurdles. Okay, I think the hurdles will be jumped. I think it will be available. It's still a way off. Now, what sometimes happens is once it's submitted, or once Health Canada approves it before the provinces agree to it, sometimes it's available on what's called a compassionate basis for sicker patients, for more extreme cases, for no other options. But that's up to the company, we're grateful when they do. We cannot fault them when they don't. They may have other reasons for not being able to do it. I hope that answers.
I think so. Thank you. And we'll be discussing more about the process for bringing new treatments to you next week. Jamie mentioned it in the chat there, I see. So we are having a roundtable discussion next week being led by Jamie Meyer, our director, about this exact topic. So if you're interested in having more conversation about what this looks like and how we can bring some of the drugs that Dr. Langleben has talked about, treatments to you, we'll hope you will join us next week. I'll share links on how to do that in a follow-up email. Okay, we've got lots more. Here we go.
There was a question from Regin, from our translator.
Yes, and that was the one about how long it was going to
Yeah.
take to get
Yes.
sotatercept. So we've covered that one.
Well, no, it was asking about BMPR2 mutations.
Oh, do you
Just
see
popped
that?
up.
If you
Yeah.
see it, go right ahead.
Yeah. So very briefly, I think sotatercept may actually be an excellent uh, treatment for that. Several of my patients that I entered into the sotatercept trial, I know had BMPR2 mutations, and they seem to respond very nicely to the therapy. And there's an arm, again, it was the same way I mentioned scleroderma. There's another one of those arms for heritable, which included patients with BMPR2 deficiency, and sotatercept helped. Okay, next question, please.
Okay. Jazz is asking, what is the average year of survival for PAH these days?
Oh, it's a lot better. But as you see from that Canadian curve, the 5 year, but that's all comers. It's people who are very very sick and people who are mild. It's sort of a mix. It's those curves can be deceptive. I mean, they show we still have a lot of work to do, but they can be deceptive. It's telling me that the 5 year survival is about 50%. I think it's probably a bit higher than that in our centers. Okay, it might be 60%. But look, unfortunately, it's still a very serious disease in people who don't respond to the medication.
You've already talked about the availability of sotatercept, but someone's also asking, what phase is it currently in its review?
So in its review, I don't know. I know it was submitted to the Food and Drug Administration. There was, I think, a public announcement that they're going to consider it for rapid, or they're going to do some sort of rapid review in the spring of 2024 in the US.
Okay.
So that's a good sign. It's a good sign.
Sure. For sotatercept, will the treatment also be indicated for group 1 PAH patients and not just hereditary forms?
Yes, I mean, group 1 is PAH, and it included idiopathic heritable scleroderma. I think the repaired congenital heart disease. Those are the 4 big groups in there, and it seemed to show benefit in all the groups. It did show benefit.
Let me see here. Does adding a third medication after Adcirca and Opsumit often make a difference if a previously very active 56-year-old patient is failing after being treated with the above two medications for 3 months?
So our uh, the way we do things nowadays is sort of at each visit, we try and assess a patient's risk. And we used to divide it into low risk, intermediate risk, and high risk. Now, when patients are on therapy, we actually have 4 levels. We have low risk, we have something that we call intermediate low, we have something that we call intermediate high, and then high risk. Okay. And the current strategy is if you're in low risk, stay where you are, you're doing great. Okay. If you're in intermediate low and you're on 2 agents, um, yeah, you're probably okay. Although we can add another agent if you need. If you're on intermediate high, for sure you add another agent. And if you're on high risk, you should be on those intravenous or subcutaneous medications that we have in Canada. And we can debate, which agents to add and which agents to use. So if you're on 2 agents, and the bottom line is you're not at low risk, then a person probably we would add a third agent.
Okay, just a couple more questions about when sotatercept will be available, but I think you've answered those already. So if there's
Short
anything,
answers, I don't know.
yeah, we don't know, but
Yeah,
if there's
yeah.
anything else folks have about that, please feel free to ask.
It's
Um,
next year. It's going to be next year, I would hope.
Joan is asking, will patients with unrepaired CHD be considered for sotatercept?
So those patients have not been studied, and I can say I go to meetings with my colleagues who specialize also in congenital heart disease, and this is one of the questions we're asking. There's no study underway right now, to my knowledge, and I think things in terms of evaluating sotatercept, there are 2 other studies, by the way, that are running. Okay, one is called the Hyperion trial, which is taking patients quite early after starting therapy for the first time, other therapies, like very early on. And the other trial is called Zenith trial, which is for patients with advanced PAH, like on a lot of therapy and still really not doing very well at all. And so that's for them. So it's going to try and answer 2 other questions. And I think the company pretty much has their hands full trying to answer all these questions while they wait for approval. Now, after approval, I'm sure the company is going to be considering questions from clinicians because we do have other groups, patients that I think need evaluation, and we should try to answer the question. So right now, there's no news on unrepaired congenital heart disease.
Jane is asking, do you anticipate a boom in genetic testing and PH clinics across Canada in the near future? How can we as patients help this next step progress if our clinic is not initiating?
Well, so sometimes it's a resource issue. Someone's got to pay for these tests. In Quebec, we're lucky, and the government supports it. I think it also does in BC. I'm not sure. Uh, I don't know about the other provinces, and so the first thing you have to find out the tests are at least what we pay is about $1,000 or $1,500 per patient. So they're not cheap, but they're also not $1 million. Um, it's our routine now to anyone that we suspect has idiopathic PAH. If they agree, of course, we send off genetic testing. But you need an infrastructure. You need geneticists. You need genetic counseling. You need the ability to screen other family members should you find something. You need to be able to, sit and talk to the patients and inform them the pros and cons of genetic testing. At least in the US, they can affect insurance, for instance. And so all these things have to be discussed. Now, let me turn that question around. Here's a different question. Would it be nice to have specific genetic information on everyone in our practices? Absolutely. That's how we're going to get to precision medicine. Okay. But right now in 2023, other than telling someone, oh, you have a mutation, there may be other family members, There's nothing specific to do about it right now. There will be very shortly, by the way, because we're going to start finding that everyone that looks the same, if you take 10 people with PAH, that seems to be idiopathic and line them up next to each other, you're going to find that five have, or let's say four have a mutation, X, another has another mutation Y, another has a mutation Z, and three people you won't find a mutation. Okay, so if you then have specific treatments for X, Y, Z, you want to give them those treatments as opposed to just everything.
Thank you.
Okay.
Catherine is asking, prostacyclin medications for PAH. Is the future positive for these? Question.
So they're very potent agents. I mean, intravenous epoprostenol is still our strongest agent. And even now, the world guidelines say that if you're in high risk and even intermediate high, you should be going towards those agents. You know, no one likes walking around with a pump. No one likes having catheters, okay? But I can tell you, um, I've had many patients live decades, several decades on those agents, and the people had arrived quite sick. So for our sickest patients, you know, despite the quality of life issues, it's still the best choice, unquestionably. Now, you know, will we need it in the future as we find better agents to affect cell therapy? That's a separate question. And the flip side of that is how quickly are these new therapies going to work? Because if someone comes into my clinic and is really very ill and really very close to death, actually, or risk of death, I want to hammer them with the best, most rapid therapy to save them, to buy them time, maybe to let the other agent kick in. So if it takes weeks to months for these new therapies to unblock the blocked pipes, we need something beforehand to save the patient, to give them the time for the pipes to unblock. And so we may end up with a strategy where we're using a lot of our current conventional therapies for a while as the other medications take effect. We have no evidence that we can stop any of our current medications when we add these new antiproliferative therapies. That's a question on everybody's mind. In other words, let's say, you know, I give someone new therapy X and suddenly they're fantastic. What can I stop for them? We don't know. And that has to be studied in a very, very organized fashion. And so I am sure those studies will begin as soon as we get approval of these agents.
There's a lot coming, isn't there?
Yeah, it's exciting.
Um,
Believe me.
yeah, I'm sure. Got a great question here.
Yeah.
If all PH patients were in the PH registry, would that help accelerate clinical trials?
Well, yes. I mean, it does help. It does help because it gives each clinic a handle on what their population is and who might be eligible for trial X and who might be eligible for trial Y. And unless, you know, it's a very small clinic with a very small practice, except none of us have that. We've all, I think, got you know, large, busy clinics, unfortunately. And so the registry does help. The other thing the registry can do is look at, you know, like I showed you that curve, sort of large population statistics, and and that also helps. But for an individual trial, the issue is really identifying the patients because not everyone with PAH can get into a trial. There are many inclusion and exclusion criteria that have to be satisfied. And it doesn't help anyone to cheat and sort of try to squeeze patients into a trial when they don't fit, because then the results come out muddy and nobody gets a good answer. I'm very strict about who I include in trials. And it's, you know, you know, I there's a temptation to stretch things. We never do. We never do.
Jane is asking, speaking of pumps, we were just talking about that. The Carapul pump, is there any news if the pump will become more streamlined and less cumbersome? That would be
I can't see that happening because it's an adaptation of a pump that was originally designed, I think, to give chemotherapy and antibiotics, and that's the real market for the company. It's not Carapol, so I can't see that pump getting smaller or changing its design. There aren't enough people on Carapol or epoprostenol worldwide to justify that. There have been attempts in Europe and elsewhere to use a pump that's implanted like a pacemaker under the skin. And it's available in Europe. And I actually saw one of my colleagues in Israel managing a patient with it because it has to be refilled and it has to be done by under X-ray observation so that your needle goes into the right spot in the pump, etc. And it's great for the patient because it's under the skin. There's no risk of catheter infections, etc. Um, but I don't think that that's going to be arriving anytime soon in Canada.
okay. Jane is asking, unfortunately, she wasn't eligible for the sotatercept trials. Is there other ways to gain access before Health Canada approval?
Not really, unless you meet the criteria for a trial. And believe me, I have patients, who could really use it, and I can't get it for them. It's a very difficult time for clinicians when you feel you have a good tool in your hand. But um, the one thing you don't want to do is mess up the approval, because if you mess it up, no one's going to get it. And so we just sort of have to sweat things out with our patients until these treatments become available.
Jamie wants to know, what about inhaled therapies?
Is that our Jamie?
Yeah.
Hi. Um, what about inhaled therapies? So the imatinib I showed you is inhaled. Um, there are other agents that are going to be inhaled, and it's uh, a very elegant way to get drugs get medications into the lungs. And so I think increasingly people are going to look at ways to do it. Um, there's an inhaled form of treprostinil. In Canada, we know it as Remodulin, which is given subcutaneously. Um, Inhaled treprostinil was recently shown to help patients with interstitial lung disease. It's not PAH. It's pH related to certain types of lung disease, and the medication is given in an inhaled form, which again is a very encouraging way to do it. It's not available in Canada.
Okay, we've got two more questions. I know we've hit
Okay.
our hour. Do you mind
It's,
a
it's
couple
my
more?
pleasure. It's my pleasure.
Okay, for those that can stick with us, I've got two more. So we've got a patient asking, what should a patient do if a doctor is telling them that they're very likely to end up having a lung transplant soon? Is it too late, or is there somewhere that they can go or something they can do to extend their time until better treatment is out? So maybe to avoid that transplant.
Well, if your doctor thinks you need a lung transplant, um, you should at least go and be evaluated at the lung transplant center so that they get to know you. PAH, unfortunately, is a little bit like walking on the edge of a cliff. Okay. You don't know when the ground's going to give way under you. And if you're not ready with some sort of parachute, I don't need to tell you what happens. And so I view lung transplant as a parachute. It's really our last recourse. It's not a bad recourse, but it's a big deal, of course, but it's 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 I'm happy to have it as a recourse. Okay. And if your doctor thinks that you should at least be evaluated and have them see you, get to know you, decide that you would be a good candidate, that all the tests are ready, so that if you feel the ground loosening or your doctor feels the ground loosening under you, he can get you there fast. That's my approach to it. Okay. Now, what can you do in the meantime? Well, maybe something will come along that works, but you can't count on that necessarily. Okay. You can't count on it. The earth may begin to move, and so you've got to be ready.
Last question. Is there
Yeah.
anyone out there who's already doing precision medicine therapeutics or different treatments for individual patients?
With PAH, you mean?
Yes, I believe so. I'm going to
Well,
assume that's the question.
without getting into it, we do genetic analysis and everything, and everyone, sorry, with idiopathic PH, if they agree, it has steered us already different ways. There are certain mutations that I know will never respond to my therapies, and those people get immediately referred to a lung transplant program. There are other mutations that um, uh, very rare ones that respond to other very specific therapies. I don't want to get into it today. And so those people are getting different therapies than our current pH medications. But the only way to know who's a candidate for that is to do the genetic screening.
Any final thoughts before we go, Dr. Langleben? Thank you so much. This is really
I,
informative.
I believe we're living in a much happier time than when I started practice, which was a very desperate time. I think the future looks very bright. I think we have fantastic scientists in Canada and worldwide. I mean, my colleagues are doing, stellar basic research, and we're very optimistic that increasingly we're going to come across compounds and be able to tell who they're going to work for and really offer benefit to people. Using the word cure is very hard, but if I said to one of my patients the other day that if I could promise them a 50-year remission, I'd be thrilled, and they should be too.
Well, it sounds like a lot of hope for the future anyway.
Yeah, really.
Thank you so
Thank
much,
you.
everyone, for joining us today. And thank you again, Dr. Langleben. I truly appreciate your time.
My great pleasure. Bye,
Bye,
everyone.
everyone. Thank you.